Students, let us see rapid review of COVID-19. For more detailed information, I have already done a session on oxygen therapy in COVID-19 patient. You can look in the AIMS capsule updated 2021. So it covers all the oxygen device right from simple nasal cannula to high flow nasal cannula. And there is also a COVID-19 integrated capsule containing microbiology, medicine, radiology, PSM. Now this is for regular class rapid review of COVID-19 under 30 minutes. Let us see. The causative agent is SARS-CoV-2. SARS-CoV-2 means severe acute respiratory syndrome. Severe acute respiratory syndrome causing coronavirus. Coronavirus second type. The first type happened in 2003. This is the second type. So the agent is SARS-CoV-2. It means severe acute respiratory syndrome causing coronavirus 2. And the disease name is COVID-19. COVID-19 means coronaviral disease. So COVID-19 means corona viral disease, and it was first identified in the year 2019. So this is what is this virus making us do. It is making us run for our lives for the past 1.5 years. So it is just like disease name is malaria, causative agent is plasmodium, disease name is COVID-19, causative agent is SARS-CoV-2. Now before COVID, this was our position. We were not worried about any hand sanitation, face mask or social distancing. During COVID, this was my position for about 16 to 18 hours in a day, doing a lot of duties. Then what next? What next is getting vaccinated and staying safe. Coming to the phases of COVID-19 infection, it can be divided into an early infection phase. In this phase, what happens is, if you consider this is the nasal epithelial cells. The portal of entry is nasal epithelial cells, and on the nasal epithelial cells you will be having ACE2 receptors. On the nasal epithelial cells there are important receptors called as ACE2 receptors. So these receptors are the portal of entry. So if this is the coronavirus, the spike protein can come and sit on these receptors. So they'll ask you what are the important receptors for COVID or coronavirus entry. It is ACE2 receptors. So they first enter the nose. If your immunity is good, so it will stop at nasal infection phase only. Patients will be having some mild symptoms such as rhinitis, cold. More than that, or light fever, more than that, patient will not have any symptoms. Now if your immunity is not proper, your body's defense mechanism is not proper, it can go into pulmonary phase and also a dangerous phenomena called as severe hyperinflammatory phase. Now this pulmonary phase and severe hyperinflammatory phase can be overlapping. First let us see what happens in the pulmonary phase. So within the pulmonary phase, now these virus particles enter the lung. In the lung, the target cell will be alveolar type 2 cells. Again on the alveolar type 2 cells, you can have ACE2 receptors. So the virus binds to the alveolar type 2 cells. So once the virus binds to the alveolar type 2 cells, what will happen? Consider this is the alveolus and let this be the blood vessel. Let this be the blood vessel, students. Now the virus is coming and binding to alveolar type 2 cells. So consider this is the virus, it is binding to alveolar type 2 cells, and because of binding to alveolar type 2 cells, it will cause epithelial damage, and adjacent to epithelium generally you will have endothelium, and there will also be severe endothelial damage. So see here, there will be damage to epithelium and endothelium. So there will be damage to epithelium and endothelium. damage to epithelium and endothelium. So just like in ARDS. Now because of this damage, there will be a leak from the circulation, notorious cells called as neutrophils. These neutrophils will gain access into the alveoli. Next step is leukocyte recruitment. What are those leukocytes? Neutrophils. And wherever neutrophils go, what is its function? Inflammatory damage. So it is going to cause inflammatory damage and formation of exudate. So there will be pulmonary damage. Because lungs are getting affected, the gas exchange of that alveoli will be affected. This results in hypoxemia. Because of pulmonary damage, the gas exchange in that alveoli will be affected. That results in hypoxemia. And if this damage is happening at multiple areas in the lung, this patient can progress to ARDS. So it is similar to ARDS. So the alveolar type 2 cells are damaged. There will be epithelial and endothelial damage. Because of a leak, neutrophils enter, and there will be pulmonary damage, hypoxemia. If the damage is at multiple areas, it can progress to ARDS. And one more important thing in pulmonary phase is there is endothelial damage. There is endothelial damage, and this endothelial damage can be very severe. So this endothelial damage, the endothelial damage can be very severe. Whenever there is endothelial damage, what will happen? Platelets will aggregate. So there will be increased platelet aggregation. Whenever there is endothelial damage, there can be platelet aggregation. Now whenever platelets are aggregated, ultimately what will be formed? There will be formation of thrombi. There will be formation of thrombi. This is very, very important. So because of platelet aggregation within the blood vessel, there will be microthrombi formation. There will be microthrombi formation. Now once these microthrombi are formed, it can occlude the capillaries. It can occlude the capillaries. So because of this microthrombi is formed, your body gradually tries to break this thrombi. So it is a usual defense mechanism. See, wherever thrombi is there, your body will try to break it. So whenever microthrombi are getting broken down, what will increase in your body? The D dimer will increase. So frequently asked question, why there is increased D dimer? Why there is increased D dimer in COVID-19 disease? Because of endothelial damage, there will be platelet aggregation. Because of platelet aggregation, microthrombi will be formed. And when these microthrombi are getting damaged, there will be increased D dimer. So more D dimer means more microthrombi have formed. So whenever more microthrombi have been formed, the pulmonary vasculature can get occluded and gaseous exchange will not happen. So to counter this microthrombi, we will give anticoagulation, because there are thrombi formation. So to make that thrombi not to form or not to extend, we will be giving anticoagulation in COVID-19. Now this is the pulmonary phase. So patient can have hypoxemia and he can progress to ARDS. But in few patients, their immunity behaves in an abnormal manner. See, what happens is, normally in your immune cells are just like soldiers. So they will just see the terrorist and they will shoot him. But in few, what happens is, now your immune cells will start behaving like a suicide squad. So suicide squad in the sense, they go there and they blast themselves. So whenever a suicide squad attack is happening, not only the terrorist, whatever is present in that area will destroy. This phenomena is called as that hyperinflammatory phase. See, we don't know why it is happening in only few patients. In only few patients, their immune cells will become very angry. They will start working like a suicide squad and they will start releasing all the mediators. So what happens is, your immune cells will become very, very angry and they will break. So these immune cells will break, and from the immune cells all the mediators will come out suddenly just like a storm. This phenomena is called as cytokine storm. In few, the host inflammatory response continues to amplify. Once they continues to amplify, there will be a systemic inflammation, and because of all these immune cells are breaking down just like a suicide squad, all the cytokines will be released suddenly like a storm. This phenomena is called as cytokine storm, and out of these cytokines released, most important mediator is IL-6. Most important mediator is IL-6, and because of these cytokines, they go and hit various parts of the body. Previously the damage was only in the lungs. Now these immune cells have become angry. They go and destroy whatever they see. That results in multi-organ dysfunction. Multi-organ dysfunction. MODS means multi-organ dysfunction. Multi-organ dysfunction or multi-organ damage syndrome. Multi-organ damage syndrome. And major mediator in this cytokine storm is IL-6. Your immune cells will become very, very angry, and they break themselves, resulting in release of cytokines suddenly just like a storm. That results in multi-organ damage, and major mediator here is IL-6. And now you have understood why IL-6 increases in COVID-19. So it is a marker of hyperinflammatory response. And also point to note is, lymphocytes are very, very vulnerable to the virus. The virus can directly attack the lymphocytes. The virus can directly attack the lymphocytes. Once it directly attacks the lymphocytes, it can destroy the lymphocytes, resulting in lymphopenia. Because virus is directly attacking the lymphocytes, damaging the lymphocytes, there can be lymphopenia. So elevated D dimer can be seen, lymphopenia can be seen, IL-6 elevation can be seen. Apart from this, what are the important lab markers in this disease? What are the important lab markers? So let us see the important lab markers. So the CRP, ferritin will be elevated. D dimer will be elevated. We know why D dimer is elevated. Because of microthrombi formation, your body will try to break those microthrombi. So there will be D dimer elevation. Then what is the reason for CRP and ferritin to be elevated? So point to note here is, this CRP and ferritin are acute phase reactants produced by your liver. So whenever there is an inflammatory response, these inflammatory cytokines can stimulate the liver. Inflammatory cytokines can stimulate liver. Inflammatory cytokines can stimulate liver to produce CRP and ferritin. CRP, C-reactive protein, and ferritin is also a protein produced by liver. So in this inflammatory response, what happens is, these inflammatory cytokines, they will stimulate the liver to produce CRP and ferritin. Because of that, in the blood, CRP ferritin is elevated. Because of endothelial damage, microthrombi formation, D dimer will be elevated. And this LDH is a non-specific marker for tissue injury. There is systemic inflammation, cytokine storm, multi-organ damage. That's why what will happen? There will be elevation of LDH because of various tissue injury. Troponin is a marker for cardiac injury. Troponin is a marker for cardiac injury. AST, ALT, whenever there is liver injury. Creatinine kinase, whenever there is muscle injury. So all this indicates there is some hyperinflammatory response that is responsible for damage to various organs in the body. CRP, ferritin, D-dimer can be elevated, LDH can be elevated, troponin can be elevated, AST, ALT indicates liver injury, creatine kinase indicates muscle injury. I'll try to explain you how the immune system behaves in COVID-19 with an example. Routine day immune system will be like this. So just like Professor Banner, cool and calm. Virus dealt by either antibodies or the infected cells from your body will be cleared. So there will be no issue at all. Now what happens in a severe hyperinflammatory response is this Banner becomes a Hulk. So your immune system is becoming angry and it is becoming like Hulk. Now if you see, Hulk knows only one thing, smash everything. He knows only one thing, that is smash everything. Now if you see in this image, he is not only destroying the aliens, he is also destroying the buildings. Those buildings are nothing but tissues. So there will be a cytokine storm. Your immune cells become angry, releases so many inflammatory mediators, and that can result in multi-organ damage. So this is a simple way to understand, but actually immune system is very complicated. Very simple way. In few, this Banner becomes a Hulk and smashes everything. Why it happens only in few, we don't know the exact reason, we don't know the exact mechanism. Now how to bring down this inflammatory response? So practice points. First, calm down Hulk with his girlfriend. The sun is really getting low. You use a steroid. Now if patient is not responding to steroid, you should knock down Hulk with Hulk Buster, that is anti-IL-6. So anti-IL-6 is tocilizumab. So it is just like initially you try to calm down the immune response with help of steroid. If it is not working, you are going to knock down the immune response with anti-IL-6, and anti-IL-6 used in management of COVID-19 is tocilizumab. Now you have understood why there is a hyperinflammatory response, why the markers CRP, ferritin, D-dimer are increasing, why IL-6 can increase, and why there is lymphopenia. Coming to clinical features. To understand clinical features, there is a simple mnemonic designed by me. It is called as focused at. F stands for fever. O stands for ocular symptoms. C stands for cough or cold. U stands for unusual tiredness. S stands for shortness of breath due to lung damage. This another S stands for anosmia, smell loss. You know that in COVID-19 there is nasal epithelial involvement. Nasal epithelium is getting involved by virus. So what is the function of nasal epithelium? Olfaction. Because that epithelium is getting involved, there can be olfactory dysfunction. Because of that olfactory dysfunction, patient can have anosmia. Then in the GI tract also there are ACE2 receptors. Now if the ACE2 receptors in upper GIT are involved, there will be irritation of upper GIT resulting in emesis. If ACE2 receptors in lower GIT are involved, there will be irritation of lower GIT resulting in diarrhea. Patient can have aching headache, so headache, body pains, and patient can have throat pain. The clinical features you can remember with a simple mnemonic focused at: fever, ocular symptoms, cough or cold, unusual tiredness, shortness of breath, anosmia, emesis, diarrhea, aching head or body, throat pain. Coming to diagnosis, gold standard will be RT-PCR, polymerase chain reaction. The result you will get in 4 to 6 hours. Whereas Indian technology, you have TrueNAT. TrueNAT is also a molecular assay. You get the result in 1 to 2 hours. And for all this, we go either for nasal or throat swab. When compared to throat swab, in the nasal swab, the yield is more. So preferred is generally nasal swab. And rapid antigen kits, There is antigen. Don't think it is a blood test. It is also a swab test. Rapid antigen kits, we will get the result 15 to 20 minutes. So there are also other tests in market, but used frequently are these. Gold standard is RT-PCR. We can use TrueNAT. We can also go for rapid antigen kits. The result you will get in within 15 to 20 minutes. Nasal swab, throat swab. So preferred is generally nasal swab. Coming to the radiology, initially chest X-ray might be normal. Later you can see an interstitial pattern, bilateral haziness. Because this is a viral pneumonia, generally will have atypical pattern of presentation. Initially normal, later you can see some bilateral involvement. You can see in this image, students, there is a haziness here and there. So haziness here and there can be bilateral involvement. And if you take a CT scan, you could see the classical areas of involvement. Again, in CT scan, there will be bilateral involvement mostly in the posterior and peripheral parts of the lung. So what you can see? Initially, there will be only mild haziness. This mild haziness, it is called as, ground glass opacity. You can see in this image, students. See, this everything is the normal lung. See, normal lung. But what do you see here? This is the ground glass opacity. Slightly white, mild haziness. And later you can notice more increase in density. This more increase in density is called as consolidation. Very important. Either there will be initially mild haziness. This initial mild haziness is called as ground glass opacity. Later there will be more dense opacities. These dense opacities are called as consolidation. You should be confident in differentiating these two. Can you see the difference? Mild haziness. This is ground glass opacity. More increase in density. This is called as consolidation, students. This is called as consolidation. Coming to the clinical syndromes associated with COVID-19. We can classify it as mild, moderate, severe. Mild generally is upper respiratory tract symptom. Patient can be having some throat pain, rhinitis, with or without fever. Nothing to worry. Mild upper respiratory tract symptoms with or without fever. Moderate. Now the oxygen starts to fall. SpO2 less than or equal to 93% on room air, and respiratory rate will be more than or equal to 24 per minute. So this is the guideline. When SpO2 drops to 93 or respiratory rate reaches 24, that is moderate. Then when do you call it as severe pneumonia? Now respiratory rate has crossed beyond 30 and oxygen level has fallen less than 90. Now if you find a patient with any of these features, let it be moderate case or severe case, this requires admission. Oxygenation parameters and respiratory rate parameters requiring admission will be moderate to severe category. Patients belonging to moderate to severe category require admission, students. Apart from this, there are few worsening symptoms. When you see the patient, if patient is having this, patient should be admitted. So worsening symptoms include patient is he having any altered sensorium. Because of continuous hypoxemia, he might have developed altered sensorium. Any severe dehydration. Because of the illness, he is not taking fluid properly. There is dehydration. Because of continuous hypoxemia, there can be cyanosis. Is this patient having any respiratory distress? Then any persisting chest pain. Why will chest pain happen in COVID-19 pneumonia? Because there can be myocarditis, there can be pulmonary thrombus formation. All this can cause a chest pain. Reduction in urine output. when there is multi-organ dysfunction, there can be kidney involvement resulting in decrease in urine output. So the admission criteria, either moderate to severe case, either moderate to severe case, or any one of the following, any one of the following. So patient can belong to moderate to severe category or any one of the following: altered sensorium, severe dehydration, cyanosis, respiratory distress, persisting chest pain, reduced urine output. Admission criteria, either patient's oxygenation parameters moderate to severe, or he is having any one of these worsening symptoms. Coming to the guidelines, so we have taken the guidelines, recent AIMS guidelines and also DGHS guidelines. So we have put all together, and whatever that I am going to discuss now is the most recent guidelines. So whenever it changes, I will update. Now there is a COVID-19 patient. Now you have to divide whether this fellow is belonging to mild category, moderate category or severe category. Severe category we will discuss in the next slide. In mild illness, most importantly, you should ask him to isolate at home, home isolation, or you can send him to COVID care center. So these COVID care centers are nothing but modified function halls or hotels. They are not medical facilities. They will have only facility for patients accommodation, and you should give symptomatic care. Just like for fever, you can prescribe him paracetamol. If at all there is some rhinitis, you can give some antihistamine. Whereas tab, ivermectin, HCQ, no definite evidence. Recent studies have shown no need to give this. So as of now, no need to give this tab, ivermectin or HCQ. And recent DGHS guidelines has also removed ivermectin, HCQ. And if the patient is having symptoms beyond 5 days, you can give inhaled steroid. What is the inhaled steroid given? Inhaled budesonide. If patient is having symptoms more than 5 days, more than 5 days is having fever, cough, in them you can give inhaled budesonide. And you should keep a watch on high risk patients. If they are home isolated, so this patient should be kept on monitoring either by teleconsultation or in few areas once in a day directly medical officer will go. So who are those high risk patients? Age more than 60, age more than 60. Patient is having CAD, coronary artery disease, comorbidities, CKD, chronic kidney disease, CLD, chronic liver disease, hypertension, diabetes, chronic lung disease, obesity. If patient is having any one of these risk factor, he should be on close monitoring. If at all he develops any worsening symptom, immediately he should be admitted to the hospital. Whereas moderate case, this generally requires hospital admission. You should admit him in ward or COVID health care center. In COVID health care center, there will be oxygen facility. There may be no ICU, but there will be oxygen facility and medical officer. So these are also modified health centers with oxygen facility, and oxygen support should be given to these patients, and your target SpO2 should be 92 to 96. Whereas always in COPD, even if he is having COVID also, the target SpO2 should be maintained 88 to 92. In COPD specifically, you should maintain 88 to 92. Then this patient requires prone positioning to improve oxygenation, steroid to bring down that inflammatory response, and because of damage to the endothelium, there will be thrombi formation within the vessel. To take care of thrombi, we give anticoagulation, and you might consider remdesivir. See, remdesivir is not a magical drug. It is only having limited evidence. Depending upon the clinician's perspective, he can consider remdesivir. See, remdesivir is not mandatory. Remdesivir is not mandatory in COVID according to new guidelines. So clinician can take his decision according to his discretion. According to clinician, he might consider remdesivir in moderate case. So in moderate case, most important will be oxygen support, steroid, anticoagulation and prone position. This remdesivir is not a mandatory drug. Now, if the patient is having severe COVID, you should admit him in ICU of a dedicated COVID hospital, and you should start him on high flow nasal oxygen or non-invasive ventilation can be used. So, this is the high flow nasal cannula. Advantage of this is it can give about 40 to 60 liters of oxygen per minute. Oxygen it can deliver about 40 to 60 liters per minute. Your routine flow meter, the capacity is only 15 liters. So, this can give up to 40 to 60 liters per minute. And what will be the other medical management? You should give steroid, you should give anticoagulation, you may consider remdesivir and anti-IL-6. And steroids are only drugs which are known to decrease mortality, especially in very sick COVID-19 patients. If they ask you in very sick COVID-19 patients, what is the drug that can decrease mortality? Your answer should be steroid. Anticoagulation will also decrease mortality, but steroid is having more evidence. Now, if the patient is not improving with NIV or high flow nasal cannula, now this patient might require invasive mechanical ventilation. IMV means invasive mechanical ventilation. What are the indications? His breathing is absent or obstructed. His breathing is absent or obstructed. He has developed severe respiratory distress. You are giving oxygen, you are giving NIV, still he is having respiratory distress. There is central cyanosis, bluish discoloration of his tongue. He has developed shock, coma, convulsions. If you find any of this, this patient is not fit for high flow nasal cannula or NIV, immediately you should intubate with necessary precautions. And intubation is generally invasive procedure and you need to go close to the patient. You should take very strict precautions like I have shown in this image. Intubate with necessary precautions, and you can ventilate as per ARDS protocol. Ultimately, the lung damage will result in ARDS. So, you should ventilate as per ARDS protocol. Already I have discussed ARDS protocol in detail. Low tidal volume mechanical ventilation, P-plat less than 30 centimeter H2O, giving him PEEP, sedation and neuromuscular blockade, taking care of his fluid and electrolyte balance. Same as treatment of ARDS, you should proceed after intubating the patient. This is regarding mild, moderate and severe COVID-19 management. Now, there are a few new drugs, few new weapons to fight against COVID-19. So, I am only discussing the drugs which have been approved in India. First is Virafin. Virafin is pegylated interferon 2 alpha. Virafin is pegylated interferon 2 alpha. It is an immunomodulator. It can decrease the inflammatory response, and it is also known to decrease viral replication. Then we have baricitinib. Baricitinib is a Janus kinase inhibitor. The mechanism is, why it is used is, it can decrease the viral entry into the cell, and it can also function as anti-inflammatory immunomodulator. Baricitinib, Janus kinase inhibitor, decreases the viral entry into cell and functions as immunomodulator. Then we have the antibody cocktail. Kesirivimab, imdevimab, bamlanivimab, istevimab. So, what is this antibody cocktail? So, mab means monoclonal antibodies. We are giving together, so it is called as the famous antibody cocktail. We are combining antibodies, so it is called as a cocktail. So, what we are going to do here is, you know that the virus, so the SARS-CoV-2 virus is having spike proteins. So, these are the important virulent structures. So, these spike proteins go and bind to the cell and enter the cell. Now, what these monoclonal antibodies do is, so these are MABs. They go and attach to the spike protein. They go and attach to the spike protein. So, like this, you can see this monoclonal antibody will go and attach to the spike proteins. because the antibody is attaching to the spike protein. Now the spike protein cannot go and penetrate this cell. Because of that, there will be decreased viral entry into the cell. These monoclonal antibodies bind to the spike protein and decrease the viral entry into the cell. We also have 2-deoxy-D-glucose. It can decrease the glycolysis in the infected cells, and virus replication also requires energy from glycolysis. Because glycolysis is inhibited, virus cannot survive. There will be reduction in viral survival. This is the 2-deoxy-D-glucose. Then we have molnupiravir. It is similar to favipiravir that have been used last year. Molnupiravir, it can also decrease viral replication by inhibition of RNA dependent RNA polymerase. But keep in mind, students, these are all the drugs which have been approved newly. No drug is included in the national algorithm. Is Virafin, is baricitinib, is antibody cocktail, is deoxy-D-glucose, or is molnupiravir included in the national guidelines? The answer is no. Whatever I have discussed, only that drugs are approved and to be given according to the national guidelines. So these are some additional drugs: Virafin, baricitinib, kesirivimab, imdevimab, bamlanivimab, istivimab, 2-deoxy-D-glucose, molnupiravir. Now what is the drug of choice? See, I as a doctor, I feel I need a drug of choice which can hit COVID-19 like this. But unfortunately, there is no drug of choice up to now. That's why we have to listen to all these people who speak rubbish. So that's why till we get a drug of choice, whatever these people speak, that will only be followed by public. So they say that we are having wonder drugs. You people who are practicing modern medicine, you don't have drug of choice. We have so many wonder drugs. They keep on saying those rubbish things. Now practice points, very important. The treatment in our country for moderate to severe cases is SARA. See, Zara is not the name of the staff nurse, or she is not Sara Ali Khan. But for once in your lifetime, remember Sara Ali Khan when you are treating moderate to severe cases. What is this SARA? S stands for steroid, A stands for anticoagulation, R stands for required oxygen. What is the oxygen required? You should deliver to the patient and prone position. And another A stands for antiviral based on limited evidence. So very, very important: steroid, anticoagulation, required oxygen, and antiviral. See that all the patients with COVID-19 moderate to severe, you are giving them SARA, not Sara Ali Khan. That SARA, that is steroid, anticoagulation, required oxygen, and antiviral. Now let us try to solve some questions. There was a 55-year-old male, case of type 2 diabetes, hypertension, regular medications. He is having 1 week history of shortness of breath and cough. He got COVID vaccine 10 days back. Fever was initially touching low grade, now 104. He has taken vitamins. His RT-PCR report is COVID positive. Examination pulse rate 95. Respiratory rate 28, oxygen saturation 92. What will be the next step in management? What is the category of the patient? It is moderate. In moderate, you admit him in ward and give him SARA. So this is a moderate case. ICU option is out. Admit in ward, yes. Oxygen, yes. Remdesivir, maybe. Plasma therapy. So plasma therapy no longer indicated, students. Let us see option C. Admit in ward, yes. Oxygen, yes. Steroid, yes. Heparin. Heparin is nothing but anticoagulation. So the best answer is option C. The best answer is option C. In INICET 2021, severe COVID-19 infection in children, what is included in treatment regimen? See, let it be children or adults. Most important is only steroid. In children, remdesivir is not indicated, ivermectin is not indicated. So this is a direct question. In children also you can give steroids. Remdesivir is not indicated. Ivermectin is also not indicated. Which of the following drug, it was given in 2020, known to decrease mortality? If they ask you decrease mortality, the single best answer is steroid. So what is this steroid here? It is dexamethasone. So the dexamethasone is the steroid. Then drug not used in severe COVID-19 infection. We can give dexasteroid, we can give anticoagulation. Remdesivir can be used based on limited evidence. No role of HCQ. According to new guidelines, no role of HCQ even in mild cases. Identify the following oxygen delivery. What is this? This is a high flow nasal cannula. Various oxygen delivery devices I have discussed in a complete special video. You can go through. That can also be asked in your exam. Hospital admission criteria for COVID-19 patient. Age more than 60 individually is not a criteria. If at all you take age more than 60 for admission, then all the hospitals will be filled in our country. So age, more age is not a criteria for admission. It is a criteria for close monitoring even at home. SpO2 less than 92, yes. Such respiratory rate more than 25, yes. Pressure in the chest, so persisting chest pain is also an admission criteria. So the answer is only B, C, D. SpO2 less than 92, respiratory rate more than 25, and persistent pain in the chest. So this is regarding COVID-19 in a nutshell, students. You can go through the detailed video for more information.